Hey guys, it's Dr. Bass coming to you with AV blocks and AV dissociation this week for our EKG rhythms. And I think I may have told you the last time I saw you guys online a couple weeks ago, this is my very favorite EKG lecture. Blocks are a lot of fun. They can be confusing, but once you get it in your mind, uh, where the P's are, do the P's measure out, what's the PR interval, it sort of becomes a fun detective type situation when you're trying to figure out what exactly is this patient in? What rhythm is this? So let's get started. So the rhythms we're going to talk about today, first degree AV block, which is associated with a sinus rhythm. We tend to say normal sinus rhythm with first degree AV block, or sinus tachycardia with first degree AV block. Second degree AV block, which is Mobitz type 1, second degree AV block, which is Mobitz type 2, and third degree AV block. We're going to talk about the monitoring, treatment, and nursing implications for those arrhythmias and assessing hemodynamic stability and emergency response. So let's once again review the anatomy, physiology, and function of the atrioventricular junction. And when we talk about the atrioventricular junction, we're talking about the AV node and the bundle of His. And the normal cardiac impulse starts in the SA node in the upper right atrium. It spreads across the atrial myocardium via Bachmann's bundle, the internodal pathways, and then once the electrical impulse has spread, you get an atrial contraction. The impulse then travels to the atrioventricular node, down through the bundle of His and down the right and left bundle branches. It ends in the Purkinje fibers, which transmit the impulse to the ventricles. If you remember, one of the key components of the AV junction is to hold that impulse for a short period of time until the atria can contract. So the first rhythm we're going to talk about, it's actually not a rhythm, it's something that happens within a sinus rhythm, is first degree AV block. So a first degree AV block is defined as a PR interval consistently longer than 0.2 seconds. That is 5 small boxes or 1 large box in every cycle, and the PQRS-T sequence is otherwise normal. So if you remember, the PR interval is normally 0.12 or 0.20 seconds. And your small boxes are each worth 0.4. So greater than 0.2 means that you have 5 small boxes. Your PR interval is greater than 5 small boxes, or 1 large box, essentially. So a PR interval consistently longer than 0.20 seconds indicates a first degree AV block. And what that means is there is a longer delay between atrial and ventricular repolarization. There's a 1-to-1 ratio between the P waves and the QRSs in first degree AV block, and that is different than second and third degree AV blocks. So it's relatively common, prevalence of approximately 7%, and where you typically see it is in highly trained athletes that have extremely supernormal cardiovagal tone. In other words, their heart rates are usually in the 40s. It's usually asymptomatic. Most of the time, we don't even remark about it other than to say there's a first degree AV block. It's not uncommon for young, healthy people to have PR intervals slightly over 0.2 seconds. It may indicate a history of MI or myocarditis, and that, of course, is going to come along with your history taking and what the patient is there for as to whether you're going to suspect that this first degree AV block is something that is pathophysiological versus something that is sort of normal physiology in someone who's a highly trained athlete. and it can represent the first sign of a degenerative process of the AV conduction system. So the description of a first-degree AV block, it lengthens the delay between the atrial and ventricular repolarization. Typically, you're going to have a rate 60 to 100. The rhythm is going to be regular. Everything is normal, like a normal sinus rhythm, essentially. You've got P waves that are 1-to-1, they're sinus. You've got a normal QRS complex and T wave. However, the difference is your PR interval is consistently greater than 0.2 seconds. Your QRS and your QT intervals are normal. The relationship between your P waves and the QRSs are normal. The best leads are V1, 2, and V5, but it's really recognizable in all leads. And we'll take a look at that here. So if you look at this 12-lead EKG, it doesn't have a beautiful, I'm looking over here in lead 2. It's not extremely obvious that this is a first-degree heart block like some of the ones I've seen, but if you look up at the top, circled in red, you can see that the PR interval is 0.212, so it's greater than 0.2. So this is one that's just barely too long, just barely. There are others that are much more obvious, like this one, for instance. If you take a look at this EKG, this 12 lead, you can see this is a 16-year-old male, and the PR interval is 0.348. And when you look at this, the first thing to me that I see is, wow, look how long that PR interval is. This is a sinus rhythm, so we are going to call this a sinus rhythm with first-degree AV block. Another example, you can see the P over here right at the very end of the T wave. And this is a really long PR interval. If we counted this, I would say it would be 1, 2, 3, 4, 5, 6, 7. 7, so 7 times 0.4, so this would be 0.28, this PR interval. And you can see it's consistent all the way across the strip. The next strip below it, the PR interval, you can see measures out as 0.34. So once again, this is simply a sinus rhythm where the PR interval is consistently longer than 0.2. Causes: MI, Lyme disease, lupus, some type of congenital issue or some type of AV nodal disease, myocarditis, electrolyte imbalances. The main reason that you're going to see first-degree AV block, however, is increased vagal tone from people who are in really, really good shape, a lot of athletic training. It can also be medication-induced. And you notice digoxin's down there, my favorite drug for causing issues with cardiac dysrhythmias. So, common signs and symptoms in first-degree AV block. We've already said this condition doesn't usually require any type of investigation or treatment if it's asymptomatic, particularly if the patient is young and healthy. If there's some reason to suspect a metabolic disturbance, it may be worth checking the electrolytes. If the patient is experiencing cardiac symptoms, or there's reason to suspect some type of coronary artery disease, then you may want to refer them to a cardiologist. Follow-up EKGs on an annual basis can be used to monitor for progression of the heart block if you think there's a pathological cause going on, or if the patient's on some type of AV node blocking medication. First-degree heart block is a relative contraindication to the use of nodes that may delay AV nodal conduction, such as those that were listed above. And they must be used with caution in any of those patients that may have a first-degree AV block. So it's usually an incidental finding. If an MI, you may see other things accompanying the first-degree heart block, such as chest pain, tightness, upper body pain, discomfort, the typical signs of a myocardial infarction. If it's myocarditis, you may see chest pain, shortness of breath, fluid retention, fatigue, other signs and symptoms that go along with a viral infection. And there is a study that found that first-degree AV block is associated with an increase of atrial fibrillation, pacemaker implantation, and all-cause mortality. So it's not always innocuous. Sometimes it is an indication that things are starting to go wrong with the conduction system of the heart. But if you have it in a young, healthy person that is athletic, it's a pretty normal finding. So if we see a first-degree AV block on a patient's EKG, what are we going to do? We're going to get a 12 lead. We're going to possibly take a look at electrolyte and drug levels, cardiac enzyme levels, look for infection, some type of thyroid, the myxedema, or connective tissue disease studies, if clinical evaluation suggests systemic illness. But once again, I do want to emphasize, most of the time we see this first-degree heart block in a young, healthy person, and we don't really give it a second thought. Only if it's associated with other pathology going on with the patient do we really take a strong look at it. So typically there is no treatment usually necessary for this particular block. If we feel like it's medication that's causing the prolongation, then obviously we're going to stop that. We're going to correct the electrolyte imbalance. No treatment usually necessary unless it's associated with an MI or infection, and then yearly monitoring for preventative purposes. They may eventually end up with a pacemaker down the road, but that's when the first-degree AV block progresses to much more serious blocks that we're going to take a look at here in the next few slides. The nursing implications we've already talked about determine if there's an underlying cause such as medication, infection, past MI, myocarditis, look at the electrolyte imbalance and MI indicators, yearly EKGs to determine if further intervention is necessary. Ramifications of not receiving early EKGs or yearly EKGs, include the possibility of undiagnosed second or third degree AV block or AFib. The patient may eventually need a pacemaker if the block progresses into a more serious nature. So the next two blocks we're going to talk about are second degree AV block, Mobitz type 1, that is also referred to as Wenckebach, and then second degree AV block, Mobitz type 2. So what is a second degree block? Second degree AV blocks occur when the conduction is intermittently blocked from reaching the ventricles along the AV junction pathway. So what's happening in first degree is it's just taking longer to be transmitted, basically. All of your impulses that are coming from the SA node are being transmitted down to the ventricles in first degree heart block. In second degree heart block, the impulses are intermittently blocked from going down to the ventricles. Some atrial depolarizations are conducted to the ventricles, producing a QRS response, while some atrial depolarizations are blocked, leaving lone P waves without an associated QRS. There are two types of second degree heart block. Type 1 is the same as Mobitz type 1 or Wenckebach. It occurs in the AV node. It's associated with functional suppression of AV conduction, typically drugs or reversible ischemia. And that is one of the reasons when we talk about associated with functional suppression, it's one of the reasons that when we look at type 1, a second degree type 1 block, we don't consider it as critical as a second degree type 2 block. In a second degree type 2 block or Mobitz type 2, this occurs below the AV node at the bundle of His or at the bundle branches. This is typically associated with structural damage like infarction, fibrosis, necrosis, and it's a more serious situation. So let's talk about second degree AV block, Mobitz type 1 or Wenckebach first. The PR interval gradually lengthens in each successive cycle until the final P wave of the series fails to produce a QRS. and we talk about that as a dropped QRS or a blocked beat. Prolongation of the PR interval is present in 2 or more consecutive beats. The conduction resumes after the blocked beat and the cycle restarts. So note the short cycles of Winky-Bach patterns can produce group beating that look like couplets of premature beats. Don't be fooled. And when I talk about Winky-Bach, that's one of the most important things. When you look at an EKG strip and you see some groupings, that's something that comes to my mind is, oh, is this a Winky-Bach? Or, like we said in the slide, is this premature beats? How are we going to tell? Basically, what happens in Winky-Bach is you get PR intervals that progressively get longer until there's a dropped QRS. So you can see here in this very first rhythm here, I'm trying to bring up my pen. Hold on. There we go. So there we go. Let me see if I can. There we go. So there's my pen. Sorry, didn't mean to. Let me erase that so that doesn't confuse you. So if you take a look at this very first strip here, or this very first QRS, I'm sorry, I'm using a. If you look at the very first QRS, you can see that the PR interval looks to be about, let's see, 1, 2, 3, 4, 5, 6, 6.5 blocks, 6.5 small blocks. So that's sort of a like a 0.24, maybe a little bit larger. Then when you come over to this next PR interval, it gets a little bit longer. The PR interval there is about 1, 2, 3, 4, 5, 6, 7 blocks. So that PR interval has progressively lengthened. If you look at the PR interval here, okay, and then you've got a dropped QRS. You have a P wave here. Here's your P wave, okay? This P wave looks exactly the same as the previous two, but you do not have a QRS after it. Now, how do you know that that is not a blocked PAC? The reason that's not a blocked PAC is because your PR, your P to Ps are going to measure out. So in other words, that P wave is not going to come in early, okay? Your P to Ps are going to measure out. Your R to Rs do not measure out here because you have a dropped QRS. So it's cyclic with PR intervals that get longer and longer until a QRS is dropped and it repeats the same cycle. So as you can see, it starts back up again over here. And I keep losing my, there we go. So it starts again here. And we've got this really small, see how short the PR interval is? It's normal, but it's short again. Then it's starting to lengthen. So that's a little bit longer right here. And then you can see it, it's really obvious that it's gotten longer here, okay, right here. So short, long, longer. Then we come here and we see the actual drop. There's the P wave with no QRS. All right, let me erase all of these. So, okay, there we go. So what you have is you've got PRs that continually lengthen and get longer until there's a dropped QRS. Then it sort of gets reset. It goes back to a normal PR. Then the PRs again get longer and longer until there's a dropped QRS, okay? So the pairings or the groupings is a classic picture of Winky-Bach. And the reason that those Ps without the QRSs are not non-conducted or blocked PACs is because the P to P comes in on time, okay? So The first impulse passes through the AV node with normal conduction, but the cells in the AV node exhibit post-repolarization refractoriness. So they're a little refractory here, and that's going to vary. The second impulse now requires a prolonged depolarization time and a longer recovery time, which increases the PR interval. This cycle continues until an impulse arrives at the AV node during the effective refractory period. The cells cannot depolarize, and the impulse is not passed along to the ventricles, therefore you have a dropped QRS. During that skipped beat, the refractoriness of the cells return to normal, and so the next impulse conducts through the AV node without any difficulty, and the cycle begins again. So as you saw with the re-entry phenomenon, refractoriness is really key for this particular type of rhythm. So the conduction ratio is the ratio of P waves to QRS complexes. So an example, a 3-to-1 block means the EKG has 3 P waves for every QRS complex. No consistent pattern, it's a variable conduction ratio. We talked a little bit about this in when we're talking about atrial flutter, but we talk about most common in Mobitz type 1, 3-to-2, 4-to-3, 5-to-4. You can have different conduction ratios with your Winky-Bach. So here's a 12-lead EKG that's showing Winky-Bach. Here's another example of a 12-lead. Again, it's sort of hard to see it in the 12-lead because you don't get a long enough strip, so you don't get to see the pairings. But if you look here in lead 2, I'm just going to circle the entire part of it. Oops, sorry guys. If you look here in lead 2, you can see that the very first, let me recircle that. I don't know why I'm having so much trouble with the, okay. So if you take a look here, all right, this is your lead 2, okay, and you go over the very first QRS in that lead 2 is the one right before the drop. You see the dropped beat here. Here's the P wave with no QRS, and then you pick back up with a normal PR interval right here. Then we're going to have a little bit longer PR interval right here. And then if we saw the additional part of the strip, you would see a drop, okay? So let's look at a longer strip. It becomes more obvious when you see a 6-second strip. So here's an example of a 6-second strip. The P waves and the QRS complexes are normal, but they are dropped beats, and that means P waves without QRS complexes. The PR interval progressively lengthens, and the R to R interval progressively shortens until a beat is dropped. This leads to grouped beating. The block is almost always within the AV node, as we talked about. Another example, Mobitz type 1, you can see in the top one the PR is lengthening progressively with successive beats until one sinus P wave is not conducted. Then the cycle repeats itself. Notice that the PR interval after the non-conducted P wave is shorter than the PR interval of the beat just before it. As we said, it resets. It all has to do with refractory periods. And the AV node has enough time to reset itself. And so once a QRS is dropped, the AV node resets itself and accepts the next impulse in a normal manner. And the best strip is the bottom one, and that you can clearly see the sort of the grouping pattern that we're talking about. You get a progressive increase in the PR intervals with the third sinus P wave in each sequence not followed by a QRS complex. Mobitz type 1 or Winky-Bach produces a characteristically syncopated rhythm with grouping of the QRS complexes or group beating. So the atrial rate is based on the SA node, how much, how fast the SA node is firing. The ventricular rate depends on how many are conducted, basically. So this is sort of a rhythm where looking at a 6-second strip would give us the best ventricular rate because it's going to be irregular. The key is the P to P intervals are regular. That's what's going to tell you that you don't have a non-conducted PAC here. The P to P intervals are regular. The R to R intervals usually shorten within the groupings. You have a sinus P wave. Your QRSs, you get dropped in a repeating pattern. Your T wave is normal. Your intervals, your PR lengthens with each beat until it's not conducted to the ventricles. The QRSs are usually 0.12, and they can appear irregular because the R to R intervals shorten, and your QT is normal. The relationship varies. As we said, if the conduction varies, the relationship between P's to QRS is going to vary. So look for QRS clusters. The P to P intervals remain unchanged. Why? Because the sinus node is fine. The problem is in the AV node. The R to R intervals shorten slightly. The R to R interval surrounding the blocked impulse is less than twice the two shortest R to R intervals, and we're going to talk about that in the next slide for clarification. And your best leads 2, 3, or AVF, where you can easily visualize the P wave. So here you can see an example of 4 to 3 conduction. You've got 4 P waves to 3 R waves. You see the PR interval is progressively lengthening, 0.36, 0.46, 0.48, and then it's blocked. Then it goes back to, sort of sets back to semi-normal, 0.34 seconds. You can see how the R to R's measure out. So B is less than A and C is less than 2 times B. And that's what it was talking about in the previous slide, less than 2 times the R to R of the first two, of these first 2 intervals. And this is where you have your dropped, C is where you have your dropped beat. So the causes of Mobitz type 1 or Wenckebach, it can be caused by parasympathetic excess that inhibits the AV node, or drugs that mimic parasympathetic effects, or poisons can also do the same thing. If you talk about organophosphate poisons that cause excessive parasympathetic stimulation. It can be normal in young adults and athletes. It usually does not progress in that population. There's our favorite, digitoxicity. Other drugs that can cause it, beta blockers, calcium channel blockers, amiodarone. It can be caused by acute inferior wall myocardial infarction, myocarditis following surgery, particularly after valve replacement. So symptoms, sometimes there's symptoms, typically not. Patients can get lightheaded, dizzy, or syncopal. It is more common to have symptoms in Mobitz type 2. And again, as with a lot of these rhythms, we're going to be concerned about them based on what the patient presentation is. Are they having chest pain? Are they bradycardic? Is the heart rate really, really slow? Not only is the heart rate slow, we're dropping a QRS every, 3 or 4 P waves, so that makes things even worse. Symptomatic patients may have signs of hypoperfusion, including hypotension and weak pulses. I will tell you, most of the patients that I see with Mobitz type 1 are totally fine, have no issues, are not symptomatic in any way. That's the most common thing. The treatment and implications for Mobitz type 1, it's usually benign with a low risk of progression to 3rd-degree heart block. And I think we talked about it a little bit in 1st-degree heart block. If something pathophysiological is going on, something bad is going on in someone's heart, and we think they have a 1st-degree AV block because they're having an MI or they have myocarditis, those are the kinds of things that can progress later on down the line to a 3rd-degree heart block, which is obviously worse than a 1st-degree or a 2nd-degree heart block. But Mobitz type 1 in particular usually has a very low risk of progressing to 3rd-degree heart block. So that's why we don't get quite as concerned about it like we do about the next second-degree heart block, which is Mobitz type 2. If it's chronic and the patient tolerates it, there's no treatment necessary. We may need to use drug therapy and electronic pacing in very rare cases. Those are very rare interventions for these patients. Symptomatic patients usually respond to atropine, and permanent pacing is rarely required. These patients, you want to monitor them on telemetry, evaluate them for signs and symptoms of any type of hypertension, thready pulses, dizziness, lightheadedness. Are they symptomatic is what we're looking for. Alert the provider, educate the patient on recognizing those symptoms, and we'll want IV access on them. So let's talk now about second-degree AV block Mobitz type 2. So second-degree AV block Mobitz type 2 is much less common and significantly more serious. We have intermittent, non-conducted P waves without progressive prolongation of the PR interval. So the PR interval here stays the same. We have multiple paced atrial depolarizations, which are blocked before conduction to the ventricles is successful. We end up, again, as we talked about in atrial flutter, we can end up with 2-to-1 or 3-to-1 conductive rates, and that's P to QRSs. A lot of times they have very slow ventricular rates. Note, the P wave is regular and punctual. It's not premature like a non-conducted PAC. And once again, your P to Ps are going to march out. The mechanism of Mobitz type 2, it's often preceded by a bundle branch block pattern, which is a widened QRS complex in the conducted beats. The dropped ventricular beats are due to intermittent blocking of the remaining conducting bundle branch. This is happening in the distal conduction system. It may or may not have a consistent pattern. Because this is occurring in the distal portion, a backup pacemaker may fail to escape during dropped beats, and this patient basically can become syncopal and have a sudden death can occur because the backup pacemaker is sort of in a refractory period and can't generate a beat. The high mortality rate occurs when it's a complication of acute MI. When you see second degree type 2 in a patient who is having an acute MI, there is a high mortality rate with this particular rhythm. Onset of instability may be sudden, causing syncope or sudden cardiac death. So this is a rhythm that we really, really want to pay attention to. So you can see here we've got a 6-second strip on leads 1, 2, and 3. You look at lead 2, you see all those P waves occurring. If you took your calipers and marched out each one of those P waves, the P to P would march out, okay? But we don't have a QRS for every one of those P waves. We essentially have a QRS for every 3 P waves. So that's 3-to-1 conduction. Here's an example of you can sort of see that bundle branch pattern that we talked about on the QRSs. And you can see the P waves that are occurring underneath the red arrows. So we have P waves that are going to march out, but we don't have a QRS for every P wave. And if you notice in the upper left-hand corner what the heart rate is in the 20s. So this is not typically compatible with very good perfusion. This patient is typically, if they're awake, they're very syncopal, they're complaining of dizziness, they don't feel well. And this is someone that's at very, very high risk for sudden cardiac death. Here's an example of a Mobitz type 2. It's a 3-to-1 block. You can see you have 3 Ps and 1 QRS occurring. As you can imagine, this is a really slow rate when you're only conducting a third of your impulses down to the ventricles. You're going to be very bradycardic. This patient's most likely going to be symptomatic and complaining of dizziness if they're mentally alert at all. And here's an example of a second degree type 2 where you've got varying conduction. You have an area here at the beginning where you have, I'm way up there. You have right here at the beginning, this is part of the Mobitz type 2 because you've got a P wave with no QRS. It's coming in on time. Your P to Ps are equal, but there's no QRS after it. Then you have a period of one-to-one conduction. Let's see, when you get over here to the middle, basically. And then you have another period where you've got 2-to-1 conduction. So this is a varying conduction Mobitz type 2. So the atrial rate is going to again be based on the SA node and the ventricular rate. It depends on how many impulses are conducted down to the ventricles. The P to P intervals are usually regular. The R to R intervals are regular until there's a drop in the QRS, and there may be varying conduction. This is less regular than Mobitz type 1. The waves, your P wave is sinus. Your QRS is often a widened bundle branch block pattern, which indicates slow conduction. In about 75% of the cases, you're going to see that bundle branch pattern. Your T wave is normal. Your intervals, your PR is constant and unchanged until the beat is not conducted to the ventricles. Obviously, there's no PR there. Your QRS is typically greater than 0.1, and your QT is normal around 0.44. The relationship varies. Do not confuse non-conducted PACs. Don't confuse this with a non-conducted BAC. Your P to P is regular in Mobitz type 2. It's easy to confuse with 2-to-1 Wenckebach AV block and 2-to-1 Mobitz AV block, and we're going to look at that on the next slide. Your best leads are 1, 2, and V1. So here's how we're going to differentiate between type 1 and type 2 second degree blocks. Your PR intervals in type 1 Wenckebach or Mobitz, the PR intervals gradually lengthen until the QRS is dropped. In type 2, your PR intervals are regular until the QRS is dropped. So the PR intervals are lengthening in one type, they're regular in the other type. In type 1 or Wenckebach, your QRS complex in appearance and length, it's usually or typically less than 0.11, and it can appear irregular because the R to R intervals shorten. In type 2, the QRS typically appears wide in about 75% of the cases. Not all the time, however. Your R to R intervals in Wenckebach, they shorten slightly. In Mobitz type 2, they're regular until the QRS is dropped. Your conduction ratios, the most common in Wenckebach, 3-to-2, 4-to-3. So in other words, you have 3 Ps to 2 QRSs, 4 Ps to 3 QRSs, and so on and so forth. In Mobitz type 2, you typically have a really low ventricular rate. So you may have 3 Ps to 1 QRS, 2 Ps to 1 QRS. Severe Mobitz type 2, you've got 4 Ps to 1 QRS. So only 1 out of 4 of your impulses is getting down to the ventricle. So you're going to have a really, really slow rate like that rate of 20 that we saw earlier. So the causes of second degree type 2, anterior septal MI, you can have chronic fibrotic disease of the conduction system, cardiac surgery, inflammatory conditions, drugs, beta blockers, calcium channel blockers, DIG, amiodarone, autoimmune issues, hyperkalemia. Notice I did not say in this particular block, like I've said in first degree AV block or second degree type 1, those can be okay. Those can occur in patients who are in really good athletic shape. That is not a normal variant here. This is always associated with some type of significant conduction disease. The symptoms of second degree type 2, signs of extensive ischemic injury, lightheadedness, dizziness or syncope, chest pain, bradycardia. Symptomatic patients may have signs of hypoperfusion, including hypotension, weak pulses, all of those types of symptoms of poor perfusion. So the treatment for second degree type 2, if it's associated with an acute MI, we're going to put a pacemaker in this patient, electronic pacemaker intervention. It mandates immediate admission for cardiac monitoring, backup temporary pacing, and ultimately insertion of a permanent pacemaker. Sometimes they may do, I have never seen this, this is just a theoretical thing. I don't know if Dr. Riley has seen it, but sometimes they may try and slow down the sinus node with carotid sinus massage so that the conducting tissue has time to repolarize so that it can actually accept an impulse from the SA node. Atropine, exercise, and catecholamines are contraindicated in Mobitz type 2. Isoproterenol, which is a pure beta drug, can help escape the pacemakers, but the problem with isoproterenol, we talk about it in terms of it sort of beats your heart to death, basically. If you have somebody who's having an MI and they're already ischemic, the last thing we want to do is increase their O2 demand. So the nursing implications for this type of block: monitor and be prepared to assist with emergency insertion of temporary pacemaker. Monitor patient medications. You don't want to suppress further conduction. And obviously the patient and the family is going to have to be educated about what type of pacemaker, wound management, etc. Is going on once the patient has that implanted. So last but certainly not least is third degree AV block. And we talk about that, we say AV dissociation. The basics for third degree block: it occurs when no supraventricular impulses, zero, from the SA node or the atria are propagated down to the ventricles. It requires a latent subsidiary pacemaker way, way down in the conduction system. The atria and the ventricles are beating independently. And if you can imagine the atria and the ventricles beating independently, I'm sure you can imagine the fact that they're not in sync. So any type of atrial kick and ventricular contraction, those are just not in sync at all. So you're not going to get great cardiac output. So the best leads to see this in are leads 1, 2, and V1. The atrial rate is going to be faster than the ventricular rate. 40 to 60 beats in the junction, less than 40 if it's coming from the idioventricular sites. The P wave, those are going to be consistent in shape and rhythm, and the QRS complex can actually be narrow or wide. The issue here is that the atria is beating totally independently of the ventricles. There is no true PR interval. Even though you may look at a rhythm and think you may possibly see a PR interval, it's actually not associated in any way with the QRS. And if the junctional pacemaker is what's pacemaking the heart, the QRS will be less than 0.1. If you have a idioventricular pacemaker that's pacemaking the heart, you're going to have a wide complex. The relationship between the P's and the QRS's is not going to be 1-to-1. There are going to be more P waves than there are QRS complexes, and the rhythm is usually regular. So I've been working on some videos trying to just discover some more interesting things to do online for EKGs. And so if you guys would just click on this link and it will show you the conduction pattern in third degree heart block, basically where all the impulses are being blocked at the AV junction. Nothing is going down to the ventricles, so the atria are going on their own and the ventricles are going on their own. So here's an example of third degree heart block. The P waves are indicated by the red arrows. You can see that the P waves march out. They have regular intervals. The QRS complexes, which are a little bit wide, So it's coming from a little further down in the junction, probably at the very top of the bundle of His, not way down in the ventricles. Those QRS complexes indicated in blue are also regular. Now, when you first look at this, you might think, oh, wow, there's a PR interval there. You would be very mistaken in thinking that. Because if you look, sorry, I'm trying to get if you look maybe at this one right here, you might say, oh, look at that. That's a PR interval. But if you go on down the line, there's no consistency whatsoever among the PR intervals. So if you wanted to look at the next one, I mean, look how you think, oh, well, maybe that's a PR, maybe that's Winky-Bach, because you've got a short and then a long one, and then you've got a drop over here. Let's say that you're thinking that maybe this one is an actual drop. Let me find out where I am here. There we go. Let's say you may, oh, well, there's where it dropped. The issue is that your R to Rs are regular. Your QRSs are coming in on time. Your P waves are regular. If this were a Winky-Bach, you would have a pause. Your R to Rs are not regular, okay? And when you start looking at this strip overall, basically what happens is you go, oh my God, look at all those P waves. And you measure your P waves out, you realize that there is no connection between the P waves and the QRSs. They're both basically just firing on their own. So this is a third-degree heart block. More examples of third-degree heart block. The top one, I would say, is very common looking. See how you've got the wide QRS? Because the pacemaker that's pacing the ventricles is down lower. So you're going to have a wide QRS, and then you've got these Ps that are just occurring independently of the QRSs. The bottom one, your pacemaker for your ventricles, is obviously up high in the bundle of His, or very low in the junction. But once again, you have way more Ps than you do QRSs. There is absolutely no association between the P waves and the QRSs. So there are different types of causes of third degree block. We already talked a little bit about second degree type 2 having some idiopathic fibrosis, different types of disease processes like connective tissue disease, those types of things. Those can cause third degree heart block. Acute causes of third degree heart block, inferior MI, DIG toxicity, rheumatic fever. What we're going to see, though, is symptoms that are due to low ventricular rates. The patients are typically symptomatic: fatigue, dyspnea, dizziness, and syncope. And once again, the treatment for third-degree heart block, cardiac monitoring, correct any type of underlying drug toxicities. You know what they're referring to here, probably DIG, but temporary pacemaker and insertion of a permanent pacemaker is what's going to happen with a third-degree heart block. If it's left untreated, ventricular standstill and sudden cardiac death is a high probability. So for nursing care, you're going to assess their hemodynamic status and their level of consciousness, understand and explain different types of pacemakers, which we're going to go over that in a different lecture with you guys, and educate your patients on new pacemakers.